Welcome to the Deep Dive. This deep dive is adapted from a clinician-written article on Mentalyc and brought to life in audio for therapists who prefer listening on the go. We're really excited to feature the expert perspective of Gargi Singh, psychologist. She wrote this really insightful piece on the need to tailor OCD treatment plans.
And since this clinical intelligence comes from Mentalyc, that's mentalist break, it probably helps to know that it's a platform designed specifically to support therapists with documentation and, streamline the whole clinical workflow.
Which is so important.
It is, because it's exactly that administrative side that can fall apart when you're trying to manage these highly adaptive treatment structures.
Right. And, that central, almost frustrating challenge of working with clients diagnosed with OCD. We're all trained that the structure required by approaches like ERP exposure and response prevention is clear.
It's very clear.
We need a hierarchy, we need systematic desensitization, consistency, but then the application is, well, it's anything but rigid.
Right.
You're sitting with a client who is often just profoundly ashamed, maybe even dealing with active suicidal ideation because of their obsessions.
And maybe significant comorbidity, too. It's never just one thing.
It's never just one thing, and that's the moment, isn't it? It's when the rigorous, systematic protocol just hits a wall of profound human fragility.
Exactly. How do you, as the clinician, honor that emotional state while still enforcing the structure that ERP demands? It's really the essential paradox of OCD treatment.
That paradox is the core tension the article unpacks. It's so easy for us to just, revert to checklist therapy. But the author stresses that while OCD is so debilitating, there is no one treatment that fits all. The plan has to be both structured and dynamic.
Designed with clear intent, but always ready to evolve as the client's internal world shifts.
So to do that, we have to look deeper than just the behavior.
We have to. The article pushes us to understand not just what the compulsion is, say, checking a door latch 15 times, but critically, why it shows up. And, in the author's words, what the behavior protects. Because that behavior, no matter how irrational it seems on the surface, is serving some kind of deep protective function for the client.
Let's lean into that for a second, because that feels like the key insight right there. If the behavior is protective, what is it typically guarding the client against?
Well, it can be so incredibly varied, and this is where the tailoring really happens. For one client, the compulsion might protect them from the perceived responsibility for a terrible outcome.
Like checking the stove so they don't cause a fire.
Exactly. They just can't tolerate the anxiety that they might cause a fire. But for another client, that same ritual might be protecting them from, a core shame rooted in past trauma. The OCD has just latched onto a controllable routine to distract from something much deeper.
So, if we understand the ritual as this sort of misguided act of self-protection, the goal shifts. It's not just about reducing the compulsion anymore. It's about building genuine self-efficacy and emotional tolerance to replace that defense mechanism.
You're seeing the client as separate from the problem. The OCD becomes the misguided protector.
Right.
And the article gives us a clear template for this dual focus. So the overall goals are pretty universal, right? Reducing frequency, tolerating distress.
Improving functioning, all the things we write in our notes.
Exactly. But the objectives have to be super specific. Smart goals, like client will delay sink washing ritual by 10 minutes over the next 3 sessions.
That move from the broad, compassionate goal to the concrete objective, it's necessary for tracking progress, but it's also a huge administrative hurdle.
Yeah, huge time sink.
When you're designing a dynamic plan that pivots every single week, manually documenting those shifting smart objectives so they satisfy payers, it takes forever.
And that administrative weight is why the article highlights the need for support systems. This is where tools like Mentalyc's AI treatment planner become so critical.
How so?
Well, it manages the structure, the insurance-ready formatting, the compliance checklists, creating smart goals linked to CPT codes. It does the heavy lifting.
Which frees you up.
It frees you, the clinician, to focus your cognitive energy on the human element. Maintaining that compassion and flexibility as you adapt the plan based on how the client actually responded to their ERP homework that week.
That's a great way to put it. The AI holds the compliance structure so the therapist can hold the client's emotional experience.
And that relational focus has to start immediately. The sample plan and the source material really emphasizes that even if you know you need to move quickly towards CBT and ERP,
you can feel that pressure.
You do.
Yeah.
But the first 2 sessions must establish a strong foundation using a Rogerian model: unconditional positive regard, authenticity, non-judgment.
I sometimes worry that, given the urgency of high-distress OCD, prioritizing the Rogerian approach in week one might feel like delaying the work. How does the article navigate that tension between speed and alliance?
It makes the case that prioritizing the alliance is actually the most efficient path. Think about it. If a client is carrying profound shame about, say, contamination obsessions they think are bizarre,
They're not going to tell you everything.
they will not be honest about the true extent of their compulsions if the container doesn't feel absolutely safe. And if you get inaccurate info, your ERP hierarchy is based on faulty data. The treatment will fail.
So the therapeutic relationship holds the anxiety that ERP is going to generate later.
It's the foundation. That non-judgment isn't just a nicety, it's a structural prerequisite for getting an accurate case history. The author is very clear that the nature of the counselor in that phase sets the tone for everything else.
And it requires us as clinicians to be really reflective in those early stages. Am I truly present? Is my non-judgment really coming across?
Right, and the article mentions that Mentalyc has a tool called Alliance Genie. When you're so focused on the client's internal world, tools like this can provide some objective, non-content insights into those alliance dynamics across sessions.
Wait, how does that work without using any recordings?
It's a mechanism for reflection on the process. It might look at objective behavioral metrics that can signal a relational shift. For example, if a client repeatedly cuts sessions short after a difficult disclosure.
Oh, interesting.
Or if there's a measurable drop in verbal engagement around certain topics. It just helps you reflect on whether that initial trust you built is holding up. It's data to aid your own reflection.
That's fascinating. Getting a metric on the relational health while you're so focused on the content of the hierarchy.
Exactly, because that plan needs to be ready to pivot based on both the alliance and the client's progress. Which brings us to the critical need for adaptation.
Right.
So weeks 2 and 3 involve psychoeducation, maybe the ABC model, identifying patterns, encouraging the client to tolerate distress.
But what if they're progressing faster than you thought?
Then you can't just keep feeding them low-level hierarchy steps. The plan has to modify, shift focus to deeper self-awareness, maybe post-recovery growth.
And conversely, if distress spikes, which, let's be honest, is almost a guarantee in ERP, the plan has to slow down.
Or you shift focus back to the mindfulness and grounding techniques that are part of the core curriculum. That responsiveness is what makes it client-centered, not just protocol-driven.
This need for constant adaptation is probably clearest when working with younger clients, which the article also gets into.
Yes, absolutely. The core principles of CBT and ERP are the same, but the delivery and the whole environment have to adapt dramatically.
So when treating children, what are some of the key adjustments we need to make?
The primary one is externalizing the problem to reduce shame. First, your psychoeducation has to be age-appropriate, using metaphors like calling OCD the worry monster or the OCD bully.
That gives the child a common enemy to fight.
Right, so they feel like it's not them that's the problem. Second, and this is non-negotiable, is parental involvement. We have to explicitly guide parents to stop accommodation behaviors.
Like giving reassurance.
Exactly.
Yeah.
Parents want to soothe their child, so they say, no, the germ won't hurt you. But that reassurance just becomes another compulsion.
It feeds the cycle.
It does. We need to give them scripts. So instead of, don't worry, a parent might say, that's the worry monster talking. We're going to be brave together.
You're stopping the system from performing the compulsion for the child.
Precisely. And third, ERP itself has to become play. If there's a contamination fear, maybe the task is putting a sticker on the scary item. Make a creative mess. And finally, school collaboration is key to make sure teachers aren't accidentally accommodating the OCD at school.
Quick pause. If the challenge of documenting this highly adaptive dynamic treatment from pediatric shifts to adult ERP pivots feels familiar, Mentalyc can help. Its AI note taker supports your documentation and clinical judgment by efficiently generating compliant notes like SOAP notes from your session inputs. This helps you capture those weekly adjustments accurately while staying fully HIPAA and SOSO2 compliant. You can explore how it works at Mentalyc.com. So going back to the adult sample plan, what really stands out is just the necessity of maintaining that human element, even when you're in the high structure phase. The article stresses that while the core work of ERP is systematic desensitization, maybe starting around week 4, the foundation of every phase relies on that trust you build back in weeks 1 and 2.
I think the most grounded takeaway from all this is that dual necessity in OCD treatment. You need the structure and you need the presence.
Structure and presence. I like that.
Even with the intensity of ERP homework continuing through the later weeks, the therapist has to remain this consistent, non-anxious presence, always modeling and teaching core skills like mindfulness and grounding.
It's that continuous reinforcement of the client's independence and their self-worth, that intentional process of removing the person from the problem, that ensures success long after they leave our office.
It absolutely is. You're empowering them to become their own therapist. And documenting these detailed, evolving steps from building the Rogerian Foundation to scaling exposure tasks and tracking those minute changes in response, it's vital for continuity of care.
And for getting paid.
And for getting paid, yes.
Yeah.
If you want support streamlining this administrative burden, making sure your progress notes satisfy payers and reflect the complexity of your approach, Mentalyc's AI Note Taker and AI Treatment Planner can help you focus more time on being present with your clients.
So if the ultimate goal of our work is empowering clients to reclaim agency over their lives, the article suggests we should track progress not just by the reduction of checking rituals or hand washing, but by the client's ability to communicate that sense of self-worth and independence apart from their disorder. So the question to think about is this: what metrics beyond the traditional compulsion count are you using to measure that deeper long-term resilience and your client's internal sense of agency? That's what we want you to mull over as you transition back to your day.